Hello, welcome again to Miami Community Health. Dr. Antony Gonzalez here with Live Longer with Dr. Antony Gonzalez. Miami Community Health Show is always here to bring you another important health topic. If you want to live longer, you got to be healthy. And one of the areas that you need to be healthy is in the kidneys. So we're celebrating Kidney Awareness, Kidney Health Month in March. What are the kidneys? What do the kidneys do for us? I've heard that the kidneys are like in our back. Are the kidneys in our back? And how important are the kidneys? And can we live without kidneys? Do we need one kidney, two kidneys? Well, we're going to learn a little bit about kidneys today. And to learn about kidneys, we brought a nephrologist, a kidney specialist, a friend of mine, a colleague from Baptist Hospital, Dr. Antony Farias. Welcome, Tony.
Thank you so much. Thanks for having me.
All righty. So tell us about yourself, a nephrologist. What is that?
First of all, I want to thank you for putting on this, show. I think it's great that we're doing this just for the, people out there to, learn. I was born and raised in this, in this great city, and I'm
Miami, MIA.
Yeah, and I'm very proud to be here. So a kidney disease doctor, what we deal with is how it's filtering the blood, and how like, in other words, we deal with the patient's blood pressure, and stuff like that. There's also a kidney doctor, which is a surgeon, and that is the urologist. So we don't deal with any type of surgery. That we leave that to our good friends in your department,
the urology. And so a nephrologist deals with things like filtering the blood that you talked about, and you talked about blood pressure. Yeah. And so what does the kidney do for us, like in our body? So
that's a great question, and I'm not sure how much time that we do have, but essentially it's going to regulate everything in our our body, from filtering the blood, from controlling the blood pressure, from I'm helping us control the salt and also a water balance. So let's say that you go a day and you're not drinking any water, you're going to produce a very concentrated urine because you want to preserve the water that you have. If you start to drink tons of a fluid, you're going to go to the bathroom more, because we are basically sensing how much water your body needs. So that's what the kidneys do. They're going to regulate all that. They also have some oxygen sensors, to say it in a very easy way. So if your blood supply is very low, it's gonna spit out a actual hormone to go to the bone marrow to make more of the red blood cells. It's also going to help with the bone metabolism, and calcium and phosphorus, and vitamin D. So it's a very important organ, and when it is not functioning well, we have to look at every single one of the things that I said, from blood pressure, a volume status, a blood levels, calcium, phosphorus, sodium, a potassium, and the list could, go on.
Wow. I mean, so I think it's important that you really demonstrated to our viewers and our listeners that it is so important. God gave us two kidneys. Do we need two kidneys?
Most people, I would say more than 90 to 95% of the population are born with two kidneys. Sometimes patients are only born with one, kidney, and they will never know that they have one kidney unless they get a, imaging study. Do we need two, kidneys? And the answer to that is no. Like I just said, some people are born with one, kidney. Also, if you have two kidneys that are, filtering well and, are working fine, you could even donate one of your kidneys to someone who's in need. And your, kidneys are, located in your back. Now, a lot of people always come to me and say, oh, I'm having, a kidney problems. And I'm like, why do you say that? And I'm like, because I have this back pain. Kidneys don't really give us pain. If you have pain and it is from the actual kidney, it's probably a kidney stone, which is very, painful. or if you have something called pyelonephritis, which is painful, which is an actual infection inside of the, a kidney. And you would know, you would have a fever of 104, maybe even a septic shock. There are some patients that I have seen, but very, rarely, that could get an actual heart attack of the, a kidney. But I've only seen like 2 or 3 in about, a 20-year, a span. So that's very, rare. Some patients ask me, well, how do I know that my kidneys are, working or not working?
That's exactly what I was going to ask. So how do people watch out for kidney problems?
Right. The only way to know is through, a blood testing. So we do a blood test, which is a routine, a blood test, and we look at a protein called the creatinine. Okay. That is an actual, a protein that's from your, muscle cells. So the more muscle mass a person has, they produce more creatinine. A patient with less muscle mass will produce less, creatinine. Regardless, it's being filtered every day. So we don't think about it, but when we go to the actual bathroom, we're getting rid of all of the creatinine for the a day. A normal level is anywhere between 0.8, let's say, to about 1.2. That's a very narrow range. So I always tell patients 1. So when it's 1.0, that's what we consider preserved a kidney function. We then get that number and plug it into a mathematical formula that'll give you a number called the estimated GFR, which is estimated glomerular filtration rate. And we use that as an actual percentage. So a normal, it's about anywhere between 60 to 100 is considered a normal, a GFR. Once your, a GFR is less than about 60 is when we say that it's not, filtering well. The other important test that people should get is a urine test. And that is to test for if there's any blood in the urine or if there's any protein in the urine. We do not want any blood in the urine, and we do not want any protein in your urine. That's very that's something that we need to look for.
And that's something that's showing that there's damage to the kidney or there's a problem with the kidney?
Yes.
Okay.
Yes. Most of the time you could have blood in your urine that could be from a kidney stone, and that's not coming from the actual kidney. And you could have a protein in your urine, and it could be from a urinary tract infection.
Okay.
So it may not be kidney damage. Specifically, there's a test that we test for called microalbuminuria, and that is from the actual kidney
itself, right?
Yeah.
Okay. So is everybody at risk for kidney disease? What are the risk factors? Male, female, age? I've always heard smoking is a problem, alcohol, for other conditions, right? So what are the risk factors to damage your kidney?
Right. So the most common would be high blood pressure, diabetes, obesity, and those are the big 3. Other risk factors, there could be a a genetic component. Nowadays we have a study that could test for over about 400 genes to see if you have a a genetic. Unfortunately, your genes are your genes. You're not going to be able to treat that. And your age, as we get older, you are at risk for your kidney function getting a little bit worse. But the things that you could control would be to carry your ideal body weight. Unfortunately, we live in a society that there's a lot of people that are obese. So that's something that they have to control. Their a blood pressure needs to be very well controlled. They have to try to have a blood pressure as close as they can to 120 over 80 or less. And the diabetic patients, it's so important that their blood sugar is almost perfect, because the last thing that they want to do is end up on the a dialysis.
Yeah. So what about other controllable risk factors like smoking or alcohol? How does that affect the kidney?
Smoking will, cause, and what they have found is that for a patient who's a smoker versus someone who does not smoke, you will have worsening of your kidney function. It doesn't matter if you have high blood pressure or if you or any other a medical condition. If you smoke cigarettes, you will get worse. Alcohol, not so much. Alcohol can affect your a liver, but it doesn't affect your a kidney.
All right. So we've heard about controlling your blood pressure, controlling your blood sugar, controlling your weight, avoiding smoking. What about what you eat? Obviously, what you eat controls your obesity, but are there certain foods that could be toxic to the kidney?
That's a great question and a very, a controversial one, I think.
Okay.
At least from my a perspective.
Or is there a special diet that we should be on, for our kidney?
And that's why I say it's a a controversial. So there's no specific food that is bad for your that's bad for you, but I feel that the way the food is processed in this country is what the problem is. So they put so many chemicals and so many preservatives in our foods that I think though that is not the best diet for you, regarding protecting your kidneys. There are certain ingredients in this country that are not allowed in other countries, which that's why I say it's a a controversial topic. People do ask me, is there a diet that's beneficial for the kidneys? There is a tendency to say that a plant-based diet is a beneficial one when it comes to kidney health. I'm not in that camp. There are some people that are very strong saying you need to be a hardcore vegan. I feel that if you eat a diet that's well balanced and you're getting fruits, vegetables, whole foods, nothing processed, and eating lean meats, I think that you'll be fine. Low salt intake is something that you need to, you need to have a salt intake of about 2,000, grams, per day. I feel that you should just avoid the processed foods. That's what
I think that's what people talk about. They talk about going around the perimeter of the supermarket, right? Going around the perimeter and staying away from the cans and all the processed stuff in the middle. So get all the fruit.
So if you get a piece of a fish, let's say a wild caught, a fresh fish, and you put a little bit of salt on it, I don't think there's a problem with that. But I do feel that the fried foods, the processed foods that's in a can, that's in a box, I think that's where the issues are.
All right. So people come to you when the primary doctor sees that their creatinine, their blood levels are off. And so they must have some type of kidney injury or kidney damage. So talk to us, who's the typical patient? Who should be seeing a nephrologist like you? Is it somebody, self-diagnosing themselves, somebody whose primary doctor sees that there's something wrong with them, their kidneys are off, not working well? What type of, talk to us a little bit about that.
Right. So, like I did say, the actual only way that they know if they're in a trouble is through the a blood test. It's important that you have a history of the a blood test, meaning that you've gone to the doctor and you've done the blood test at least twice a year, so we can see what the a trend is. So if someone has a creatinine of 1.0 and in 3 months it went to 2.0, that's an acute change. Sometimes it is reversible. So if a patient, let's say, gets a COVID, that's something that we've had to deal with. They could be a patient that has what we call a acute kidney injury. Not necessarily it's permanent damage, but it's in that event they had a baseline of 1.0 and now it's 2.0, and maybe they'll get better with the the other patients are patients with what we call CKD, chronic kidney disease, and those patients will have a a GFR of less than a 60, let's say, this a 50. And those are the patients that usually get referred to us. I think that anybody that has a GFR of less than 60 should probably be referred to us. Definitely anybody who has the microalbuminuria should probably be in the hands of a kidney a doctor.
Right. So I get a GFR. My primary doctor says your creatinine is elevated. Your GFR is 40, 50. I'm going to send you to Dr. Farias. So I go see Dr. Farias. I'm going to end up on dialysis already. Is that what's going to happen, or is that that doesn't happen right away?
So hopefully not.
Okay.
Right?
Yeah, I want people to understand that just because they go see you doesn't mean that they're going right straight to dialysis, right?
Correct. And the reason why I did mention that they should come see us when their GFR is in the 40 to 50 range is because we want to try to help that patient preserve their kidney function for as long as they can. You just went straight to the stage 5, a kidney, disease. And that's usually when your GFR is at around 15. Okay.
Okay.
So we usually put patients on the actual renal replacement therapy, which is the, a dialysis, when their GFR is less than 15.
Okay.
I usually tell my patients, because I like to use an easy, a number, when they get to about 10% of, a kidney function is when we're saying, listen, we need to do this. So my goal is that if you have a GFR of 40, or, I want to keep you there for as long as we can.
And so what are the therapies to try to keep somebody as long as you can and keep them off dialysis? Are there things that you can do in therapies to prevent them from getting to that dialysis point?
Right. So number one is blood pressure. We have to make sure that your blood pressure is as close to 120 over 70, 120 over 80 as much as we can. Diabetes, you have to have a hemoglobin A1C of 7.0. I have patients that come to my office with hemoglobin A1Cs of 12, which just for the,
explain to them what hemoglobin A1C is.
So basically that's a number that we look at. That's a, average of what your, a blood glucose is over a, 90-day period. For someone who does not have the, diabetes, you should have a hemoglobin A1C of less than 5.6, right? I have patients that come to my office with hemoglobin A1Cs of 12, 13, and these are just patients that are not controlling their, diabetes at all. Wow. So a patient with the diabetes, you want to have their hemoglobin A1C as close as you can to 7, maybe even less than 7. And that has been shown to hopefully preserve the, a kidney function. It would be great if they could go down to 5.6, but you have to be careful, because if you're injecting insulin so much that you're causing low blood sugars, that could be even, more, dangerous. The other thing is weight. People unfortunately are overweight, and I'm obese, and that is going to lead to a worsening of their actual a kidney function. So I always tell my patients, you have to try to exercise, you have to try to walk. We live in South Florida. Really, there's no excuse for you not to be able to just to go outside and go for a 30-minute a walk. And there's certain medications that patients should not take. There's a very long list, but I think the biggest one that I see that I cringe when patients tell me they take is the non-steroidal anti-inflammatory drugs. People take these medications like it's a candy, right? And that's going to hurt them. So that's, I mean, there is some other medications that people should not take, but I think the list would be too long. So that's why I feel it's important that you have a kidney doctor, so that they could go through your, medication list and tell you what they can and what they cannot.
So
take.
It sounds like to me that the treatment of somebody who's got a little bit of chronic insufficiency, has a low GFR, their kidneys are not doing well, is the same as the prevention, right?
Correct.
The blood pressure control, diabetes control, weight control, of course, avoiding the NSAIDs, the Motrins, the Advils, the ibuprofens. That's basically it. Is there a special medication that's going to get my kidneys going better, or going to rev up my kidneys to bring it back up, or?
Right. So if you have chronic kidney disease, there's no medication that's going to help you reverse that. It's kind of like what damage is in the kidney, it's probably going to stay there. So if you've been seeing a doctor and you have a GFR of 40 and you've had it for 2 years, it's probably not going to get better. Your goal is to prevent it from getting worse. There is some medications now in the market in the last 5 to 10 years that they've shown a promise. One of them has been on the market for 30, 40 years, but that's just the lisinopril or the telmisartan, which is those medications have shown to prevent the kidney function from
but that's a blood pressure medication.
That is a blood pressure medication, but it also decreases the amount of protein in your urine, and it's a medication that preserves your kidney function. The other drug that in the last 5 years we've started to use is called the SGLT2 drugs. And then you've probably seen them on the TV. It's the Farxiga or the
I've heard of it, yeah,
or the Jardians, just to name two of them. So those drugs have also shown a strong benefit in preventing the kidney function from getting worse. They also had that class of medication has also shown benefit in controlling the blood pressure. Has also shown a benefit in patients with the heart disease and a stroke preventions, and it's a diabetes drug,
right?
So it's a drug where you're killing multiple birds with one stone. So at bare minimum, any patient with chronic kidney disease should be on an ACE inhibitor or ARB, which is lisinopril or the telmisartan, and an SGLT2 inhibitor. Those are the two right now that we're using. There's another drug specifically for the diabetics called finerenone. It's also a blood pressure medication, but it's also shown a lot of a benefit in the prevention of the kidney function getting worse. Those are the 2 or 3 that we're using the most right now. The other drugs are just like you said, and it's funny because if you are going to protect your heart, you're going to protect your kidney.
Wow. Well, one of the diabetes drugs you didn't talk about is the GLP-1s, the Ozempics, the Mounjaros, the Wegovy's.
Yeah.
That's another drug that everybody's on, right?
Correct.
What about that? How's that? Is that good or bad for my kidney?
So it's actually good for your kidneys.
Okay.
It's actually good for your kidney. There was a study that was just, published maybe a year ago now that showed a benefit in patients with diabetes and kidney, disease that took that drug. And it, again, did not reverse the, kidney, disease, but it actually prevented it from getting, worse. And it had a benefit in all cause, a mortality benefit. So it's a drug that shows a lot of promise. But I do want to let our, viewers know that Tony Farias has a view on that, drug. And I think it's a great drug.
It's incredible what that drug has done.
I think
These
it's
drugs
a great
is incredible,
drug.
right?
People are losing weight, and it's definitely helping people get to their goal hemoglobin A1C, and that's amazing. However, my concern with that class of medication is that people are using that drug, they're not exercising, and they're losing muscle mass. So I've had people come to me and say, I've lost 50 pounds on this drug. And they lost 25 pounds of muscle and 25 pounds of fat, right? And if they go off the, medication, but they didn't change their, habits, they didn't change the way they eat, they didn't, go to the gym, now they've gained back those 25 pounds of fat, and the 25 pounds of, a muscle that they lost is gone. And as we get older, it's very, very hard to put on a muscle mass. So my concern with the medication is the patients are losing the
muscle.
The muscle. But the data is very strong for preserving your, kidneys.
All right. So take the GLP-1s, take the Ozempics, but do exercise and build the muscle.
Yes.
All right. So, unfortunately, there's going to be a group of patients that you're going to see their kidney function progresses to the end. They got to go on dialysis. They got to have a transplant. Talk to us about that. What happens to those group of patients at the end? Who goes on dialysis? Who has a transplant? Why do some people one way or the other?
Right. So, like I mentioned, before, once your a kidney function is at about 10% is when we start saying that they need to go on the on that type of a therapy. There's many different ways that we could help the patients. One of them that's becoming more and more popular is home therapies. So patients could actually do the actual dialysis in their own home, which we're trying to encourage the patients to do. For some patients, they'll go to a center where they'll receive the dialysis 3 times a week. I refer everybody for a transplant, and I refer anybody with a GFR of less than 20. And now I told you that I start my patients when their GFR is 10. So once their GFR is 19, I start the process.
Because it can take a long time, right?
Yes, the wait time in South Florida is probably 5 or 6 years for a kidney transplant, unless you have a donor.
Right.
If you have someone that says, "Hey, Tony, you're a great guy. I'm going to give you my a kidney," your wait time might be less. It might be 3 months, 6 months, but the wait time is long. So I always tell my patients, get on the list early, start the process so you get that wait time going, and that way when you get to be at a GFR of 10, maybe you're on dialysis for a year or 2 years, but you already have 5 years of a wait time on board. There's certain patients that are not transplant candidates. For example, patients with morbid obesity, they're not going to transplant because of the risk of the surgery. We've even had patients that have had to see you that have had to go a gastric a bypass to lose the weight to be able to get a a transplant. Patients who have severe heart failure, if their ejection fraction is 10%, the heart's only working 10%, they're not going to be able to get a transplant. Patients who have a cancer patient, so there's certain patients that are not transplant candidates. I've had patients that are 90 years old asking for a transplant, and due to the risk of the a surgery, they're not a transplant candidate. But every other patient, I think, should be at least considered for a transplant. And
a transplant's going to be better than dialysis?
Yes. Okay. The short answer is yes. A actual transplant's not a cure. A transplant is another form of renal replacement therapy. So a transplant is replacing what your native kidneys are not able to do. A transplant could work anywhere between, if you have a a rejection, maybe a year, right? Unfortunately, you don't have a rejection. Some people could have a transplant that works 5 years, 10 years, 20 years. I've had patients that have had a transplant for 30 years, and they're doing fantastic. My dad has a kidney, a transplant.
Oh, wow. Okay.
Now, having a transplant does require you to take multiple, medications. It does require you to be very cognizant of infections, because now you're taking medications to weaken your immune system so you don't have a a rejection. So maybe if your grandchild is sick, like my dad calls me, I want to go see the grandchildren. I said, sorry, they're sick and you have a transplant, you can't see them. So during COVID was a very difficult time for my dad, because I kept him away from seeing
his grandkids.
Yeah, he'd much rather see the grandkids than see me.
Of course.
That is for sure. But he's doing great. And I think that if you're able to get a transplant, it's much better than being on hemodialysis, because you're not going to a center 3 times a week. You're not doing it at home. You're able to, travel a lot easier, and you do better as far as like long term, right?
Much better.
It's a much better. I mean, I tell everyone they should get a transplant if they can.
Well, so we've learned quite a bit about kidneys. I want to thank you, first of all, for joining us. And words of wisdom. I've heard prevention is always the best, right? We don't want to see Tony Farias, except socially, right? Maybe somewhere socially. We don't want to see you in the office that we have kidney disease. Obviously, I've heard control your blood pressure, control your sugar, control your weight. Any words of wisdom? What about hydration? Do we have to drink a lot of fluids? Any parting words of wisdom for our audience?
So, I think that everyone's always heard you should drink 8 glasses of water.
My mom used to say, "Are you drinking enough water?"
Yeah.
And my mom, a retired nurse. I say, "Mom, I don't think I'm drinking enough water. I haven't peed in 3 days." And she's yelling and screaming, whatever. Right. So how much water?
Yeah. So the 8 glasses a day, I've always wondered where they came up with that, a number. And the only thing that I could think of is that in an ideal world, you would like to make 2 liters of urine a day, or at least definitely more than a liter of urine a day. So I think that's where the 8 glasses, because really what they're saying is to drink 2 liters of water, per day. A little side note on the fluid. I feel that the primary fluid people should be drinking is water.
Yeah.
I think they should not be drinking concentrated sweets. They should not be drinking juices. I think it's better if you have a whole apple, because you get the fiber.
We heard that a week ago, yes.
As opposed to apple juice.
Yeah.
And sodas, no. I mean, there's no Coca-Cola tree as far as I know. So I think water intake should be there. You should listen to your, body. If you feel thirsty, that's your body telling you need to drink, more. I think 8 glasses of water is a good standard for most people. There are certain patients with heart failure or on the dialysis that I will tell them they need to drink less. But I think anywhere between 6 to 8 glasses is a good amount. The other question I get, which we didn't touch upon about the, diet, is the, a protein intake. And this is why when I mentioned about diet, I have my own beliefs on a diet and what's actually published in the textbooks, and they don't align. The guidelines say that the protein intake should be about 0.8 grams per kilogram of a body weight, especially on a patient with chronic kidney disease. If you have a 75 kilogram person, that means that they're going to eat 60 grams of protein in a 24-hour period. I think that's way too little. And I think those patients are at risk for losing their, muscle mass. And so I personally do not recommend a protein restriction, even though that's what the guidelines are, I'm saying. I do recommend the good lean, a protein, and it could be a plant-based protein. It could be an animal, a based protein. But I think the goal for us in general, whether you have kidney disease or not have kidney disease, is to preserve your, muscle mass as much as you can, because it's going to help you age better. I think drink enough, water, 6 to 8 glasses a day. Avoid the non-steroidal anti-inflammatory drugs or any other, a medication that's toxic. Blood pressure needs to be well controlled. Avoid the concentrated, sweets. Avoid junk food. Avoid highly processed foods. A diet that's rich in fruits and vegetables. If you have diabetes, your hemoglobin A1C needs to be at 7 or less than that. And your a body weight. Your a body weight needs to be at an ideal a body weight. And you need to go to the doctor. You need to get blood tests. Urine test has to be done at least, because we got to make sure that you do not have microalbuminuria. I just went to a talk yesterday that talked about a disease called IgA nephropathy. About maybe maybe about a year ago, the goal was to keep the protein in your actual urine less to a gram a day. We were just told yesterday that the new guidelines for IgA nephropathy, the proteinuria has to be less than 500 milligrams per day.
Wow.
So half of what our goal was. So it's important, and the only way you know if you're spilling the a protein is through a urinary test. So that needs to be done a few times a year.
So you got to go to your doctor. You
Yes.
heard it from the doctor himself. Go to your doctor. Well, thank you, Tony. Thank you for joining us. Thank you for all the information. Thank you for what you do for our patients at Baptist Hospital and Baptist Health. So once again, Dr. Antony Gonzalez bringing you more information about kidney disease, celebrating Kidney Awareness Month, March. Take care of yourself and your family. Drink plenty of fluids. Avoid those medications that can damage your kidneys. Take care of your body, your blood sugar, your blood pressure, your weight. Do the exercise to maintain that muscle mass. Once again, on behalf of Dr. Farias and myself, Dr. Antony Gonzalez,